Welcome back to COM 3693, Interpersonal Health Communication. Today is going to be the final chapter in our journey of learning about interpersonal communication related to healthcare. As you probably can imagine, there are numerous ways to organize this class, and the final topic presented here makes the most logical sense to me because it's undoubtedly the most difficult to confront in healthcare: lifespan and end-of-life communication. In this final presentation, we'll discuss what end-of-life communication is and why end-of-life communication can be so difficult on the patient's family, and toward patient-physician communication. We'll also examine some of the factors why end-of-life communication can be spoiled on the part of the family making the decisions for the patient and the interdisciplinary team trying to care for the patient. This is Denise and her mom. In May of 2021, Denise's mom found out that she had just 6 months to live. Her oncologist, Dr. Lee, had told them the grim news that surgery wasn't an option and the cancer had spread throughout her body. When Denise realized that she was going to have to take on the role as her mother's primary caregiver, she was happy to repay her mom for all that her mom did for her when she was growing up. Denise assumed that her last few months with her mom were going to be spent reading together and having tough, emotionally agonizing, but closure-providing conversations. She didn't realize how the toll of the illness was going to affect her end-of-life communication with her mother. For one thing, Denise didn't realize that she would be cruel toward her mom. One notable instance happened after multiple visits to the hospital for radiation treatments. Denise was rushing home to get her son ready for an appointment, but in the parking structure of the hospital, nothing seemed to be working. She couldn't find her keys at the bottom of her purse. The ticket machine wasn't reading the parking ticket, and her credit card wasn't working. She let out a growl, signaling to her mom that her appointments and her terminal cancer were getting in the way. But she recognized that cancer never took a back seat. She realized that the constant adjustments in medication, treatment visits, and ambulatory issues left Denise chained to her mom. The role reversal with the child suddenly becoming the caregiver made them both resentful. Denise's mom even confided to Denise's husband that she was being treated like one of her kids. The other thing that strained the relationship was that Denise's mom was in denial of the terminal illness. Whenever Denise wanted to have these imagined closure-providing conversations, her mom said the topic is not open for discussion. Denise recalls that it was exhausting accommodating her mom's denial. She had to tell her doctor not to mention anything about death or dying. She had nurses remove everything that read hospice on their clothing. Before family Zoom calls, she had to prepare all family members about what is and what is not acceptable to talk about. She wanted desperately to confront her mom about her end-of-life prognosis, but she couldn't bring herself to do it. Denise recalled that this put a galaxy of space between them. According to the Center for Disease Control and Prevention, 35% of deaths happen in hospitals, 31% of deaths happen in the ill zone home, and 27% pass in long-term care facilities, which includes hospice, care homes, and nursing homes. As more and more people are dying in the care of their family members and nurses and care assistants in long-term care facilities, more attention has been given to palliative care over the recent years. Specifically, a focus on quality end-of-life communication is stressed in palliative care because it relieves suffering and improves the quality of life of both the person living with a life-limiting illness and their relatives. So what do I mean when I say end-of-life care? In short, end-of-life communication is any interpersonal communication between family, friends, providers, and others that occurs about, during, and after dying. It often signals preferences towards care during the last stages of life, and quality end-of-life communication has been shown in empirical research to reduce suffering. One distinction that should be made clear before moving forward is the social occasion or communication context in which end-of-life communication typically takes place. As I mentioned previously, communicating about death or dying with the terminally ill is usually made in the context of palliative care. Palliative care is defined as care directed at prevention or relief of symptoms aimed at improving the quality of life with respect to the patient and the needs of their families. The goal of palliative care is to optimize comfort, function, and social support of patients and their families when a cure for the illness is not possible. Palliative care lies in direct contrast with curative care, defined as therapies or medical interventions aimed at curing an illness and prolonging life. The objective of curative care is to overcome disease and promote recovery. Sometimes the lines between palliative care and curative care become blurred. Take, for instance, a person with end-stage kidney disease whose case is determined to be terminal. Although dialysis, or removing waste products and excessive water from the body, is seen as a curative care treatment, not undergoing dialysis for end-stage renal disease patients would result in their death with severe discomfort within a mere matter of weeks. So even though certain treatments are seen as curative, they may be used in palliative care as well. End-of-life communication is fraught with complexities. This is on the part of the patient's family, and even the provider. For some providers who place their ego in the biomedical model of patient care, to treat death and dying under palliative care is interpreted as a failure. Providers have to walk a careful line between focusing too much on the dying process and providing false hope to patients. Providing patients and family members false hope or insufficient information does little to help the patient make end-of-life decisions. Patients, in contrast, may be wrestling with anger and hostility towards their imminent death or go into denial about dying. In the latter case, they may not want to confront any conversations about death or dying with their providers or acknowledge that their life is on a limited time clock. For the families of patients, they're stuck in a conundrum of balancing the supposed needs of the patient with their own values, beliefs, and desires for the patient's longevity. The acceptance of death and dying for patients may happen in a series of stages. Kubler-Ross pointed out that getting to the point of having end-of-life conversations is itself a processual event comprising of different and potentially non-linear stages. Frequently, patients and family members' first responses to a diagnosis of a terminal illness or injury are to deny the possibility. In fact, patients may choose to try to isolate themselves from both providers and family members. They may even question the prognosis and or the provider's abilities to make such a diagnosis. When patients in denial become more willing to talk about their feelings, they may become angry. The patient may be bothered by the fact that they're dying instead of others, or that something they wanted to finish or do before death is not going to be accomplished. The next stage is bargaining, where it's not uncommon for patients to try to make a deal for more time, a different outcome, or even divine intervention. Finally, once the reality sets in that they have a terminal illness, patients may become depressed about the realities of their prognosis. The uncertainties about the future weigh heavily on them, forcing them to become listless and morose. There's simply no best way for providers to communicate about death and dying with their patients and their patient's family. Just like news of a pregnancy, where some will be surprised and happy, while others will be shocked and distraught, end-of-life conversations have tremendous variance. Providers are, however, reminded of some things to keep in mind when having these end-of-life conversations. First, it's generally better to avoid euphemisms like passing away, moving on, and heading toward the pearly gates. These messages convey a finality that many patients may find off-putting or even scary. Second, providers need to create the right environment for a conversation about death and dying. Choosing someplace quiet and dedicating the time for patients so as to not be rushed is critically important. Providers should also be aware of intercultural sensitivities when it comes to religious references. Some patients may not believe in the afterlife, in God, or even in heaven, so all references to a particular religion should be avoided during the conversation. Next, it's important that the provider encourage feedback, but they should make it clear that patients don't need to ask all of their questions at once and assure patients that they'll be back at a later time to discuss things further. Fifth, offering false hope can prolong the grieving process and delay important medical decisions, such as advanced directive and hospice planning, and communicating post-death wishes, such as funeral arrangements. Finally, assuring patients they will see them through the process will provide them with comfort and relieve some of their major stresses. That's pretty much all I have for this final module on end-of-life communication. In this module, you learned about what end-of-life communication is and the complexities behind this major communicative event. You should also have a better idea of the differences between curative and palliative care. You should also know how uncertainties about a terminal illness diagnosis might be interpreted by patients and how providers can best approach end-of-life conversations. Congratulations on finishing this final module for the semester. My hope is that if you find yourself in a healthcare setting interacting with patients, you can use some of the tools you learned in this class to be more patient-centered. Likewise, even if you don't find yourself in a career helping ill individuals, my hope is that the health literacy gained in this class can help you to become better interpersonal communicators in health-related situations in which you'll undoubtedly find yourself. As usual, if you have any questions, please drop them in the comments of this video or feel free to email me. Thank you for watching this video until the end and have a terrific break.